So good evening, everyone. This is Ben Knoll. I'm the Director of Patient-Centered Research at the Global Healthy Living Foundation, CreakyJoints. And I want to first say thank you to everyone who is joining the webinar today. This webinar is part of a new series of webinars we're trying to do on a regular basis to cover topics of importance to the CreakyJoints community, the online patient community, and also to members of Arthritis Power, which is our patient research registry. If you're not already a member, you can learn more by going to arthritispower.org. A couple notes before we begin. We would love to have some questions for these topics that we'll cover on this webinar. So you can write questions in the chat window, and then we'll cover them at the different points of the webinar when we'll take a break. So yeah, I see a couple questions that everyone's muted or in listen-only mode, and that's on purpose because with the webinar with so many people, we basically everyone's line is muted except the presenter during this call. And then we will unmute you if it's a question that I'll see that you're the asker, and if it needs more clarification, then I can take you off mute to clarify. But otherwise, I'll just keep things moving efficiently. I'll present the questions to our presenters tonight. So with that, I'd like to say thank you and introduce our presenters. So this topic is cardiovascular disease risk in rheumatoid arthritis. In a clinical trial, discover what helps. And we're actually covering two big topics, or even three big topics with this presentation. Something that I think a lot of people are concerned about or have heard about, which is cardiovascular disease risk in rheumatoid arthritis. Also clinical trials, what is it? What are they used for? What are the benefits and risks? And then finally, the last topic is going to bring those two together to talk about a specific trial called the Target trial that is studying cardiovascular disease risk in rheumatoid arthritis. So I'd like to introduce our two presenters tonight. They're both scientists who have been involved or led many clinical trials themselves. We have Dr. Joan Bethon. She's the director of the Division of Rheumatology at New York Presbyterian Columbia University Medical Center, and she's a professor of medicine at Columbia. We're also joined by Dr. Dan Solomon. He's also a professor of medicine at Harvard Medical School and a physician at Brigham and Women's Hospital, and is a population scientist as well. So we're delighted to be joined by such esteemed scientists and rheumatologists for this chat. And with that, I will advance to the next slide and turn it over to our presenters. Thanks.
Great. Why don't we just present, why don't we keep going one more slide? And I'll just start with an outline of what we're going to talk about tonight. And then Joan and I are going to tag team the presentation. And as was presented, we'll talk about clinical trials, we'll talk about cardiovascular disease, and then we'll combine the two to talk about a trial called the Target trial that Joan and I are the co-principal investigators on. And this is an NIH-funded trial that is now enrolling in about 35 sites around the country. And it might be something that you might have a specific personal interest in. So why don't we keep going with from there, the next slide. And Joan, I think that I'm talking about clinical trials tonight. Is that right? I can't hear you, so I'm just gonna keep going because I'm pretty sure Joan, your phone may be on mute. I'm guessing it must be. But why don't we keep going now with the clinical trials portion of this discussion? So clinical trials are an incredibly important way of learning about new therapies in clinical medicine and in rheumatology specifically. I think that I'm sure many people on the phone are on a variety of different treatments for rheumatoid arthritis, and all those different treatments have been subjected to a study through clinical trials. Clinical trials typically test one intervention against another, or one intervention against a placebo, as a way of trying to determine if they work for a given disease. So why don't we go to the next slide? So again, a clinical trial uses human participants. We often are called subjects in a study to conduct research to gain medical knowledge. And there's two types of clinical studies in general. One is an observational study, and those you might be familiar with a variety of different registries. There's something called the Framingham Heart Study. That's a large observational study, or the Nurses' Health Study. These are large observational studies that often teach us a lot, but they don't intervene on a given population. They observe what happens, and they look for associations between different interventions and different outcomes. An intervention study, on the other hand, really attempts to see whether a specific intervention, like a medication, a DMARD, might be more or less useful for a different indication like rheumatoid arthritis. And we typically describe intervention studies as clinical trials. And often you probably heard of randomized clinical trials, where we randomize patients to one arm or the other. And Target is one of those types of randomized trials, which we'll talk about a little later. And again, in clinical trials, participants are given a specific intervention, usually a medication, according to a protocol that has been preset by the investigators. And that's really what a clinical trial boils down to, is an intervention study where people receive an intervention, and oftentimes these are randomized interventions. One arm receiving the intervention, one arm receiving a different intervention or a placebo. Why don't we go to the next slide? So again, why we conduct clinical trials, I think, is not always obvious, but we're obviously trying to contribute to medical knowledge and learn something new. And most of our treatments in a condition like rheumatoid arthritis are based on clinical trials. And before drugs get approved by the Food and Drug Administration, they're subjected to clinical trials, and those data are presented to the FDA and their advisors. And then the medical knowledge that we gain from the trial allows your providers or medical teams to better diagnose, treat, and prevent disease or conditions. And really, they focus on treatment, because randomized trials are usually about testing different treatments, but they can test a different diagnostic tests, or they can test a prevention strategy. So really, all of these different aspects of medical care can be subjected to a clinical trial, but treatment trials are what we know, or we recognize most readily. And in a trial, it's possible that patients won't gain any benefit. But typically, if we're testing two proven strategies, and we're testing them in a head-to-head setting where we want to know if drug A, a TNF antagonist like Humira is better or worse than drug B, methotrexate, for example, that would be a head-to-head trial where both arms may gain from the treatments, but they may gain differently, and so we can test which one is better. Sometimes we're testing them against a completely new treatment that we don't really understand, and that's really where we think about the risk of a treatment that hasn't been studied in thousands or millions of patients. But again, some trials, and we'll talk about the Target trial, is a trial where we're testing interventions that have already been approved, and we know a lot about them. And so, trials are really a comparison of one intervention versus placebo or another active intervention. So why don't we go to the next slide? And participants in clinical trials or who are usually described as subjects in a clinical trial, it's a completely voluntary process. Patients will need to consent to be in a trial, and they need to understand the risks and potential benefits of any trial. And that when the risks and benefits have been explained and understood and all questions are answered, then somebody can give informed consent. And you've all heard of a consent form. Consent forms are not specific to trials. Oftentimes in observational studies, people will ask for consent. And the instructions that would go along in the consent form or the explanation would describe why the study is being done, what's the indications for the drugs, how long their participation would last, what happens during the research study, how many visits there are, what kinds of tests happen, if there's any specific risks or possible discomforts, possible benefits of participating. And sometimes those benefits are for the given patient. Oftentimes the benefits are to society. So we think about learning and knowledge that will improve the care that all patients receive. And so a lot of my patients who volunteer to be in studies, they will tell me that they do it because they really want to make sure that care is better for the next generation. So that's a healthy dose of altruism that a lot of patients have when they volunteer to be part of studies. And the other thing that you want to make sure is in the consent form, and it always is that alternative treatments or procedures that might be available for the condition. So not everybody's going to volunteer, and one needs to understand, if I don't volunteer, then what would my options be? So let's go to the next slide. And so again, usually in the consent procedure, when I consent patients, that's a long visit, and I'm going to spend a lot of time explaining the study and going through any questions that patients have, and that's really an important part of any consent process. This slide describes the protection of clinical trial participants, and it's important to understand that there's something called the Institutional Review Board, or the IRB, and this is a human ethics panel that will debate the relative merits of a protocol of a study trial design, and then they'll often go back and forth with the investigators, asking for revisions, asking for explanations, and then the IRB, if they decide to approve the protocol, they've deemed that it has a relative level of safety that is acceptable. But with everything, there could be potential risks, but they have to be explained clearly to patients. And obviously, the other levels of oversight are the researchers that are conducting the research. They have a responsibility to the patients participating to keep them as safe as possible. As well, the physicians that are at sites enrolling patients have a role in explaining and keeping patients safe. And then members of the research community in general oversee and they're often in a study like the Target study that we'll talk about. There's a data safety monitoring board that acts as a member of the community to make sure that the safety of the participants is first and foremost. So there's multiple levels of protection and safety. Why don't we go to the next slide? So again, the IRB makes sure the study is safe, and there's multiple other levels. You may have heard about different phases of a drug development, and we often talk about phase 1 through phase 4. Phase 3 is the level that often gets presented to the FDA before a drug is approved or not approved. And so there's a lot of work that goes on before a large randomized clinical trial that would be described as a phase 3 development of a drug. Phase 1 is where they're testing a drug. This is a new drug that that the safety of is not well understood, and that a small number of healthy volunteers would be part of usually a very brief study to understand if there's any safety concerns. And then in phase 2, the people who would be the targets for a medication, like if we were talking about rheumatoid arthritis and a new medication for rheumatoid arthritis, phase 2 would test it in people with rheumatoid arthritis to see if there's any suggestion of benefit, and again, looking at what the proper dosing might be. If there's different levels of dosing or different frequencies, those would be tested in phase 2. Phase 3 is now in a larger randomized controlled clinical trial where there's actually clinical endpoints and enough people to give real information that would allow patients, doctors, and regulators like the FDA to make a decision about whether a drug should be approved. And then phase 4 happens after a drug is approved. And the target trial, which we will describe, is really a phase 4. These are approved drugs, and we're testing to see if these approved drugs might have benefits beyond what their FDA-approved labels say. And that's what a phase 4 study is. So different phases of clinical trials are important to understand. Let's go on to the next slide. So again, we'll talk about a phase 4 trial later on in the webinar. So I don't know if anyone else wants to chime in now, but CreakyJoints has a lot of information on their website. There's a lot of information about clinical trials in general at clinicaltrials.gov, which is a government-run website that I'm sure some of you have found on your own, and that lists all clinical trials with all different drugs and what stage they're in, and it's a very useful resource. It can be hard to navigate, and I think this is a great service that CreakyJoints is providing, trying to help patients navigate 2 trials that might be useful for them. So I want to thank CreakyJoints for what they're doing. It's a real service to the community.
Hey, everyone, I'm sorry. This is Joan Bathon. Can you guys hear me?
Yes. Yeah.
So
Thanks for joining. No, that's okay. I was working up the courage to tell Dr. Solomon that he was on his own. I don't have to present the whole thing, but
I had the
glad you made it.
on my calendar at 7 o'clock instead of 6. I'm so sorry.
That's okay. No worries. So we're going to take just a couple minutes here to ask some questions about clinical trials. So for the attendees, if you have any questions specific to clinical trials, I see a couple of questions in the chat box about RA and cardiovascular disease, heart disease, pulmonary hypertension. So we'll get to those after the next section. But if there's any general questions about clinical trials, this would be the time to ask them. And I've got a couple to kick us off here. So if you'll allow me. The first question we have is, why is it that often we hear that the same drug is approved in one country, like approved in Europe or approved in the US, but not in the other country or another region of the world? I'll stop there.
Yeah, it's a great question, and it's a complicated answer, and I'll be brief. Actually, different countries have their own versions of the FDA. Europe has its own version called the European Medicines Agency, and then other countries have their own versions, Canada, etc. The US FDA is often the most stringent, and so it's often the case that things get approved elsewhere before the FDA will feel comfortable approving a drug. And again, each of the countries has their own regulatory authority, and to market a drug in a given country, most developed countries, you have to have it approved in that country. And so the regulators feel a responsibility to hold each drug accountable and make sure that it's felt safe enough to be marketed in a given country. So it's based on the fact that there's multiple regulatory agencies that have slightly different standards. And again, the FDA, I think which is a great thing, the FDA really has a very stringent and difficult bar to kind of get beyond, which I think makes our drug supply in the U.S. very safe.
And is there a reason, like either a reason that you know or could speculate why the FDA is more stringent than other, like the EMA or other agencies around the world?
Again, I think this is based on their own there's legislation that writes and regulations that the FDA lives by. And those regulations are interpreted by their regulators, and they they often hold drugs to a higher standard. Why that is, I think it's anyone's speculation, and I'm not sure it's that, I'm not sure it's that productive to go speculate. but
sure,
they,
that's fine.
Yeah.
Okay. So a question came through in the chat window from Nancy, and Nancy, I'm just going to back up one slide because your question, I think at least partially can be answered by this. You asked, is there a central URL or website to find out about clinical trials? So these are what were just presented. So there's a section on the CreakyJoints website on clinical trials where I think we've listed just a couple that are relevant for rheumatoid arthritis. And then the government maintains this website called clinicaltrials.gov that you can peruse. So you can go type in a disease or condition into the search box on that clinicaltrials.gov website and see what trials are being conducted in a particular area. So that's a pretty good one that they offer. That's the most central URL that I think that is out there. So another question that we had is about, oh, sorry, I just lost the question here. If there's so much testing done, the different phases of clinical trials, why is it that occasionally we still hear about adverse events, even death in some cases?
Sure.
I guess.
Yeah. I think it's a great question. And when the FDA approves a drug, they're saying that the relative benefits outweigh the risks. And as patients and providers, we all know that there's no free lunch in medicine. A drug like Motrin can cause death from a gastrointestinal bleed, very rarely. But any drug, even approved drugs, have risks. And when the FDA is looking at a drug, and I mean, it's public knowledge, I'm the chair of the FDA panel on arthritis, we look at we always know that every drug we're looking at has a long list of potential risks, and we're trying to weigh those against the potential benefits. And I think it's very important for patients to really understand and ask their providers to describe the potential risks as well as the benefits before anyone makes a decision about what drugs to try or what clinical trials to enroll in, because clinical trials clearly, as we talked about, have risks and benefits.
So it seems like most clinical trials, or many at least, that our patients in our community hear about, are clinical trials that require participants not be taking any medication or be naive to a certain type of medication, meaning they've never tried a certain class of meds before. Is that common, and why are they often set up like that? Why that restriction?
It's set up. Oftentimes, there's a specific question that's being tested. So, for example, we'll get to the target trial in a minute, but the target trial is trying to answer a very specific question. Among patients who have taken methotrexate and not done completely well, will these two strategies, adding a TNF blocker or adding triple therapy, how will those compare? And so I think you're absolutely right that there's a long list in trials of inclusion and exclusion criteria, how we select patients. And those criteria are put in place because you can't, to answer a specific question, you have to try to find the right population of patients. And so oftentimes there are exclusions about, if you've taken drug X, if you've taken one TNF blocker and not done well, well, then the next trial of TNF blockers might not want you to enroll, or they might want you to enroll if it's a study of people who have failed one TNF and now are trying a second TNF. So again, it's really about the clinical questions that the investigators are trying to answer. And I think that it's incumbent upon the investigators to explain that to patients, and patients should ask tough questions to try to understand why they're excluded or potentially included in a trial.
Great, thank you. And I also want to thank Charlene for that question. And there's one more question about clinical trials that's related, I think, to the last one that Diane is asking. To participate in a clinical trial, do you have to stop your current meds?
Again, that's really related to the question before. Sometimes, no, like, with a methotrexate and then you're adding another one, usually methotrexate should be continued during the duration of the trial. Sometimes, if it's a different design, it may be that you can't be on a given drug. You can't be on, more than 5 milligrams of prednisone, for example. But if you're on prednisone when you're enrolled, you should stay on that dosage. These are very detailed selection criteria that every study is a little different. And so it's hard to kind of answer that in a general sort of way. But these are the kinds of things that one should ask when someone's talking to them about a trial. Tell me exactly, can I stay on this? Do I have to stop that? What are the potential ways that the doctor can help me if I'm not feeling well during the trial?
Great, thanks. And so one final question so we can move on to the next topic. I'm just going to skip back a few slides. In phase 3, you talked about testing for drug safety and efficacy in different populations. And the question is, what does that mean exactly by a broader population? Do you mean within the population that has a particular condition like RA, or in an even broader list of conditions like people who have other autoimmune conditions?
Yeah, well, I think it's a great question, and it really, typically, it means people. Again, let's just use the example of rheumatoid arthritis, where phase 2 might be, testing a drug in people with RA, but a very specific group of people with RA to make sure the drug has some benefit. Well, then in phase 3, oftentimes we want to see if a drug has benefit in a broader group of people with rheumatoid arthritis. But again, staying within rheumatoid arthritis. Sometimes a phase 3 might be testing methotrexate for people with psoriasis or psoriatic arthritis, or there's even a study going on of methotrexate in people who might have heart disease. So sometimes phase 3 might be kind of repurposing a drug in a completely different population from what it might have been originally developed in. So it really depends on the study, but it's usually a larger group than phase 2. Phase 2 might be in 10 or 20 or 30 people, whereas phase 3 might be in 3 or 4 or 500 people or 1,000 people.
Great, thanks. So I'll advance the slides to our next topic here, but thanks for that overview. And I think the upshot from clinical trials is it's important to ask a lot of questions since it's very specific to the particular trial, it sounds like.
Mm-hmm. I think, Joan,
with that,
do you want to?
Yeah, so Ben, did you want to say something, or shall I just charge
No,
in?
I was just going to, go ahead and charge it.
Okay, so that was a great intro by Dr. Solomon, and he explained a lot of issues that will be very relevant to the discussion of this particular trial that we have going on in rheumatoid arthritis, and it's focused on cardiovascular disease. If you could go to the next slide. I don't think I can control them, can I? So an interesting thing about rheumatoid arthritis, and actually several other inflammatory diseases, is that patients who have RA are at higher risk for developing heart disease. So if you take a sampling of women with rheumatoid arthritis and compare them to a similar sampling of women of the same age who don't have rheumatoid arthritis, the risk of having a heart attack or a stroke is higher in the women who have rheumatoid arthritis, up to 1.5 or even twofold higher. And why does that occur? We don't know for absolute sure, but the theory is that if you have this chronic inflammatory disease, RA, that affects inflammation in your joints, is it possible that the rheumatoid arthritis is also affecting the blood vessels in the heart, causing inflammation there just as it does in the joints? And there is a fair amount of data now to support that there's inflammation in a lot of different organs in rheumatoid arthritis. And we know that heart attacks and strokes are fueled by inflammation, even in people without rheumatoid arthritis. So if you put the heart and blood vessels into somebody with RA, where there's a tremendous amount of inflammation already, that can drive the heart disease process even more strongly than if you did not have RA. So I hope that makes some sense. It's a little complicated. If you could go to the next slide. So if rheumatoid arthritis is a very inflammatory state and that very inflammation drives heart disease, then would it make sense when you treat rheumatoid arthritis and treat inflammation in the entire body that you could make that heart disease better, or at least prevent a heart attack or stroke? And that's what we're trying to pick apart in the target study that Dr. Solomon and I are doing, is to determine whether the treatments of rheumatoid arthritis can actually make inflammation in blood vessels better and reduce risk of heart attacks and strokes. And so that's just a very brief overview of the cardiovascular problem. And I think the next slide asks for questions. I don't think, can I advance these? Yeah, oh, I can. Or is that you, Ben? Go back to the prior slide.
That's me.
Okay. So you're controlling them, right? So at the bottom, right, you see the target trial is a clinical trial that aims to bring to light if and how the medications that we use to treat RA can influence and hopefully reduce heart disease. And I think we were going to stop there to see if there are any preliminary questions on that concept of heart disease before we move into specifics about the target trial.
Yeah, that's right. There's been a lot of interest even before the sort of live webinar. We've had questions come in about RA and heart disease. So I've got a few questions, I think, to help clarify it. One is just this, Debbie asked this about the treatment of a heart condition and simultaneously treating a systemic inflammatory response, due to RA. And I guess generally the question is, how does a patient prioritize treating those two conditions? Are they at odds with each other? It sounds like the target trial is part of trying to tease out some answers to that puzzle a little bit. But I guess what are, when you see patients in your clinic and they have heart disease, what are some of the things that you talk to them about or considerations you make as a doctor?
Those are good questions. So generally, excuse me, we want to anticipate and prevent heart problems rather than treating them after they occur. And as you're probably aware, there are a lot of risk factors for heart disease. Rheumatoid arthritis we now consider as a major risk factor for heart disease, but outside of that, there are the usual things like high cholesterol, being overweight, not getting exercise, having hypertension, having diabetes. So when we evaluate our rheumatoid arthritis patients, we're always looking at those factors as well. And if we encourage exercise, weight loss, we're checking the blood pressures, we get routine blood work, so we're looking for diabetes as well. And if we don't feel comfortable managing all of those, we certainly commonly refer the patient back to their primary care doctor for management of those features as well. So that helps in a preventive way. If somebody already is known to have atherosclerosis or hardening of the arteries from this process, we often will place them on a statin drug, which you might be familiar with, and statins reduce cholesterol or prevent new cholesterol deposition in the blood vessels. And statins can be used very safely with the RA treatments. think the question that we want to know in the target study is whether the RA treatments themselves are also helping to reduce that risk. And that's how we designed the study, to try to answer that question.
Can I just chime in there? This is Dan. Joan, I agree with everything you said. I think the general question about whether the rheumatoid arthritis treatments and the typical treatments for heart disease, whether they kind of counteract each other, is a good one. In general, I think the easy answer is no. However, to be specific, drugs like naproxen and Motrin, which are commonly used in people with arthritis, those can raise the risk of heart disease a very little bit, but they can, as well as other anti-inflammatories, Celebrex and Voltaren and other ones that people might be on. So some specific drugs can be important to ask about if they might be contraindicated or not preferred in people who have known heart disease. But and then a drug like steroids or prednisone, we think in lots of studies has been shown to increase the risk of heart disease, heart attacks, strokes. However, sometimes absolutely necessary. But I think we always try to have people on as low a dose as possible for as short a time as possible. But sometimes it's necessary. So there are specific examples where there might be drugs that kind of work at odds for the different conditions. So I think that's an important question, and it's one to discuss with your doctor. The target trial is really trying to figure out if the DMARDs, the medicines that we give for RA, whether some of them might be preferred for heart disease and actually might benefit heart disease as well as benefiting the rheumatoid arthritis. So kind of killing two birds with one stone, so to speak.
Yeah, and to make it more complicated, some of these medications like the Motrins and ibuprofens, as well as steroids, while they increase risk for heart disease on the one hand, they also decrease inflammation. So what their relative, just like Dr. Solomon was talking about the balance of benefit and risk in a drug, this is where these two drugs fall into the catch, because they can promote heart disease on the one hand and yet decrease inflammation, which is a risk factor for advancing heart disease at the same time. And another agent that we use are the TNF inhibitors like Enbrel and Humira, and there were some reports a number of years ago that they might promote heart failure in patients without rheumatoid arthritis. And so we avoid using those in people with heart failure. But we're not absolutely convinced that they really have a bad effect in our patients with rheumatoid arthritis. That's more controversial. So it does bear some discussion because they're somewhat complicated areas.
Yeah, it sounds tricky because it sounds like there's certainly some medications that someone with RA might take to manage the rheumatoid arthritis, but could increase the risk of a cardiovascular event or heart disease. Is the risk of heart disease true of other autoimmune conditions, or is this specific to RA?
Yeah, that's a good question. It seems to be relatively common to inflammatory conditions. So in lupus, the risk of heart attacks is greatly increased, even more than in rheumatoid arthritis. And in other types of inflammatory arthritis, like ankylosing spondylitis and psoriatic arthritis, the risk is increased as well. Even in just psoriasis without the arthritis, the risk is higher for heart disease. Inflammatory bowel disease, anything that causes chronic inflammation in which it's been looked at, the risk of heart disease does seem to be increased. So this makes our question that we're answering about whether drugs that are potent anti-inflammatory agents, whether they can reduce heart disease, is a very important question that might be applicable to many illnesses out, beyond just rheumatoid arthritis.
And how does the elevated risk of heart disease in RA compare with the elevated risk of heart disease in a more common condition like diabetes?
So the effect of RA, the risk conveyed by rheumatoid arthritis, is fairly equivalent to diabetes, which means to say that it's pretty important risk factor. That's been shown in a number of studies now that they're fairly equivalent. So it's not to be sneezed at, and we've been trying to educate our cardiology colleagues on this. They're starting to understand that when someone walks into their office with an autoimmune disease, that they have to be more aware of this risk.
And what about the difference in risk for men with RA versus women with RA? Have there been enough studies to even be able to start to answer that question?
Yeah, that's a good question. Women by far, in a way, are more likely to develop rheumatoid arthritis than men, and so most of the studies have had a preponderance of women in them. But as best as we can tell, the risk is relatively similar in men and women. Men have a greater baseline risk of heart disease. It starts earlier than in women. Women start to get heart disease after the menopause. Men tend to get it earlier, so they are at a higher risk to begin with. But the increase from rheumatoid arthritis is probably pretty equivalent in the two genders.
Okay. There's a lot of questions coming through, and some of them overlap. So I apologize if I miss someone's question exactly word for word. But I have a question that is it may be difficult to answer for a particular case. But someone's asking, should I stop RA treatments and take care of heart disease first? What about diet? Would a vegan diet be in order to minimize the ongoing cardiovascular disease? My cholesterol is managed and controlled, and so is my blood pressure, but both conditions still exist, and now I have discovered I am HLA B27 positive. So I think I'm hearing this in a few different cases where, concerns about the RA therapies raising their risk of embolisms or blood clots, I think, as you, or other sort of risk factors that you mentioned before, that doctors consider when they know someone has RA or has heart disease with RA. But I guess the kind of overarching question is, what can patients do to try to figure out how to prioritize or balance treating multiple conditions at the same time?
Yeah, that's a really tough issue because no one wants to take medications to begin with. There are very few people who come in saying, I really don't, I'd love to take pills and I don't mind taking medications. Everyone would prefer to be able to manage these conditions with things that they can do for themselves, like diet, like exercise, cutting this out of your diet or whatnot. And those are all really good things that we encourage, making sure you get exercise, managing your diet so you can keep your weight down, taking out foods that are not good for blood vessels, like a lot of fats and so forth, like instituting something like a Mediterranean diet can help. But these things unfortunately never are as powerful and effective in managing rheumatoid arthritis as the medications that we have approved through the FDA. They're just far more powerful. So it's always better to do both strategies, is treat the RA with FDA-approved medications that are well proven to be effective and supplement those with what you can do at home by managing a healthy diet and exercise. And you shouldn't abandon treatment of one condition to treat the other. So even though it does add more medications, it's extremely important to get your blood pressure under control and your diabetes, and that often does require medications. If you're very overweight and you can lose 30 pounds or 50 pounds or whatever, it's possible that you can come off the hypertensive medications or the diabetic medications. It's unlikely that you can come off your RA medications. So it's a complex issue, and requires a lot of conversation with your rheumatologist. But it's never a good idea to abandon one condition to treat another. It's better to manage them together. And there are strategies that you can implement at home that can help you get off some of the medications. I hope that answers it. It was a lot of issues that were raised in the last question.
I would just also echo what Joan said. I think that oftentimes people who have better controlled rheumatoid, sometimes some of the other issues become easier to control. And someone who manages their cardiovascular risk factors by stopping smoking, by maybe eating a slightly healthier diet, by trying to lose some weight and exercise, those things often actually help the RA. So I do think there's a lot of synergy between some of the management of one condition and the management of the other. And so as Joan said, thinking about like I better do this before I do this, I think is probably the wrong way to think about it. I think you want to think about having a more holistic approach that manages all of the issues. And that sometimes means having your rheumatologist and primary care doctor or cardiologist really have a good working relationship so they can talk through what are the best treatments and what are the real issues that a given patient's facing.
Yeah, I think one of the most frustrating things for patients is not having control over things. And, you only see your doctor once every couple of months, and you might get a medication or a medication adjusted or changed or whatever. And what do you do in those 2 months while you're waiting in between that? What can you do for yourself? And those are really always good things to discuss with your primary care doctor, with your rheumatologist, because there is a lot that you can do to keep yourself healthy.
What's the, I guess this is a concern people have in terms of, maybe there's no indication they have, poor heart health or cardiovascular disease currently, but are there certain tests that patients should be getting regularly to make sure that no cardiac problems sneak up on them? For example, is the CRP indicative of heart health in other ways? So some of the other lab tests that they're getting with their rheumatologist, would any of that be an indicator of things they might look at? Because I think the reality is for some patients, the rheumatologist may be their primary care physician, de facto primary care physician, so that might be the person they're coming to for everything.
Yeah, that's a great question. I mean, there's a lot about cardiovascular risk that can be determined right in the office. There's something called a Framingham risk score, and there are variations of it where you put together items, yes or no, or numbers, and can calculate your risk for heart disease. It doesn't say for sure that you have it, but things like, does your blood pressure rise above a certain level? Are you diabetic? Are you a smoker? What is your weight? What is your height? Putting these together, what's your family history? And it calculates a Framingham risk score, and it tells you, in 10 years, are you very likely to have a heart attack? Within the next 10 years, are you very likely? Are you moderately likely? Are you unlikely? And that can give you a starting point. Now, most women with rheumatoid arthritis who develop it in the 40, 60-year age often don't have too many of those risk factors. So we don't really know in that age of women what the risk is many times, or it seems low. The CRP isn't as helpful in rheumatoid arthritis. It is helpful as a risk factor in patients without inflammatory conditions, but with inflammation, it can reflect the arthritis itself. So it certainly is factored into risk factors for heart disease as well, but it's a little hard to discern, is it coming from the heart? Is it coming from the joints? So another way that we can approach looking for heart disease is a couple of imaging tests. In the target study, we're going to talk about one in particular that's not as commonly used, but one thing that you might have heard about is an ultrasound study of the arteries in your neck, looking for thickened blood vessels, cholesterol depositions called plaque. So that's a very painless procedure that can be done. There's a CT, computed tomography scan that can be done to measure the amount of calcium in the arteries of your heart. And that amount of calcium reflects thickening of the arteries, plaque deposition as well. So you can get this ultrasound of your neck, you can get a CT scan of your heart, but it's not clear how much those add to the things that can be done in the office. So you get a lot of information just in the doctor's office, and then these other tests could be done on top of that to discern how much atherosclerosis, how much hardening, thickening of the arteries you have. So those are some approaches.
It's really helpful. And then one last question. Let's leave some time to actually talk about the Target trial, because it's so interesting. It sounds like there's a lot of value in studying this topic, and a lot of concern and questions from the patient community about it. So hopefully this is an easy question. What is the prevalence of heart disease among patients, people with RA? For example, to what extent does it raise the risk of having RA? I'm sorry, for people living with RA, to what extent does it raise the risk of developing heart disease with or without a family history of cardiovascular disease?
Yeah, so it's usually considered 1.5 or 2-fold higher risk. So in other words, if 1 out of 100 people, women, 50-year-old women, if 1 out of 100 of them have a heart attack, and then you take women with rheumatoid arthritis, about 2 out of 100 will have a heart attack. So it's approximately 2-fold higher. So that doesn't sound like much, but it's actually quite a large increase in risk.
Okay.
Could I ask?
Okay,
Are there specific questions about Target? I mean, the hour's late, and I just don't want people to feel like they didn't get questions answered about Target specifically. I mean, we could talk for hours about heart disease in RA, and I'm sure we're happy to come back if that would be useful. But I just want to make sure people who have Target questions get those answered.
Yeah, and we could run through those slides.
Yeah.
Pretty quickly, I think, if you want.
Yeah, go ahead and run through those slides, and then that'll give people a chance to ask some questions about Target in the chat window.
I think, can you advance those for me, Ben? Yeah. So this is phase 4. Dr. Solomon talked about what a phase 4 is. It's using drugs that are already approved by the FDA. They're not experimental. And it's a multi-center study, so 35 sites around the country, and some Canadian sites will be added. And as we mentioned, it's aimed at understanding how different treatments approved for RA affect blood vessel inflammation. So as already mentioned, we're interested in people who are already on methotrexate. That's the first-line treatment for RA, but they're not responding well enough to it. They still have a lot of pain and swelling in the joints. So those are the kind of folks that we're interested in enrolling into the study. You can go to the next slide, Ben. So it's going to use a particular imaging type of modality called PET-CT. And that's a CT, a computed tomography scan, with an additional scan called a PET scan. And what we're doing is measuring inflammation in the blood vessels using a tracer. It's a radioactive tracer called FDG that's injected into the body, into the vein, and then the patient goes through the scanner that you can see below in the slide. And then that scan will see how much of that tracer molecule is in the blood vessels of the neck and around the aorta, the big blood vessel coming out of the heart. And to be in the study, you have to be on a no carbohydrate diet the day before. We could get into that if we want, but let's go on to the next slide. So what happens if you're interested? You contact one of the sites and talk to somebody there to see if you're a potential candidate. You can get to the sites through the Target website, or we'll be happy to put you in touch with someone in your area. With 35 to 40 sites coming on board, it's likely that there'll be somebody doing the study in an area reasonably close to you. And if you meet some of the criteria by phone, we can bring you in for a screening visit and make sure that you meet those inclusion and exclusion criteria that Dan mentioned. And then if you pass that part, then you go through your PET-CT scan. And we can't enroll you in the study right then. We have to make sure that that PET scan doesn't show anything bad. we actually had a patient who had the scan, and she ended up having some suspicious area on there and ended up having a cancer. So we are actually able to diagnose the cancer. This was one of Dr. Solomon's, actually. So once that scan is done, if everything's clean on it, then you'd come into the study and be randomized to treatment. If we could go to the next slide. The randomization means that, yeah, keep going. Randomization means that it's like flipping a coin and you get assigned either one treatment or the other. So maybe some of you are familiar with these treatments. Patients are on methotrexate on the left here. They're randomized either to get a TNF inhibitor, Enbrel or Humira, or triple therapy, which is the addition of acsulfidine, also called sulfasalazine, and Plaquenil, also called hydroxychloroquine. And both of these treatments are FDA approved. They're very typically decided upon after someone doesn't respond adequately to methotrexate. Adding either of these regimens to methotrexate is very commonly done in RA. So that's how that works. If you could go on to the next. And keep going. Yeah. This is the same thing. I don't think it says anything. So then the study is composed of 6 visits, and you can see left to right the screening, baseline with the scan, then baseline when you're actually entered the study. And then you come in every 6 weeks to be reevaluated to make sure you're tolerating the medication well, that you're not having any side effects. We draw blood to make sure that your liver's okay, your blood counts are okay. We look at your joints for swelling and tenderness. You fill out some questionnaires. And then at the end of the study, at visit 6, you have a repeat FDG PET scan, PET CT scan. And this is because now we're going to look at how much inflammation you had in your blood vessels at the baseline visit compared to how much inflammation is there after 6 months of upregulated treatment. And then we can compare the 2 arms of the study. Was there a better response in the TNF group, or was there a better response in the triple therapy group, or were they pretty equivalent? With that, you can go to the next slide. I think we're almost done. So these are the sites in the US where the study's up and running, and there have been more added, I think, since then. We're looking for 200 patients, and we have 32 currently enrolled. So there's plenty of room to join the study if you meet criteria. We'd certainly be happy to screen you. And if you go to the next, yeah, keep going. And this is just to remind you again of the Target website where you can go and get more information, or then can put you in contact with us, or our study coordinators will be happy to answer additional questions now and certainly by email, by phone in the future. That's it.
Great, thanks. So I'm going to just quickly throw a few questions your way. And just to remind people, we are recording this webinar, and we'll make a PDF of the slides available, and a link to the recorded webinar after the site on our CreakyJoints website. So we'll send that out to all the participants here. So a couple questions that have come through. I guess, well, one is, and I'll ask them. I'll kind of ask all at once, just so I won't interrupt. Do patients need to be already on particular therapies? Like, does someone need to be on methotrexate before they're eligible to participate? Are the costs of like a PET scan or other the tests and so forth covered by the study itself, or would that be part of their out-of-pocket expense or covered by their insurance? And then for folks who don't live in those particular areas from the last slide with the map of the United States, how can they get involved?
Yeah, so yes, you have to be on methotrexate already. That's the basic criterion for entry. Number 2, the costs are covered. All the costs of the study are covered. The medications are free. The scans are free. The blood work is free. The visits are free. They're all at no cost to you at all. You're doing a great favor to the study, to science in general, to the community of people who are affected by rheumatoid arthritis, and we're grateful to that. So certainly we don't charge you anything for the study. And if you don't live nearby, it becomes an issue of us helping you identify a site that is feasible for you. If it's 2 states away and 800 miles, it might not be feasible for you. If you're 4 hours away, it might be feasible, and we're happy to cover some transportation costs for you to get to and from your visits.
Great. And then just to clarify, what drugs are part of the triple therapy? I'm just going to back up to that slide here.
Yeah, so methotrexate is sort of the cornerstone for it, and then in addition to your continuing methotrexate, you would be taking asulfidine and Plaquenil. Asulfidine is also called sulfasalazine, as I mentioned, and Plaquenil is also called hydroxychloroquine. So those three, and those have been, that triple therapy has been studied in many different clinical trials and shown to be very effective and equivalent to the TNF inhibitor methotrexate combination for the joints. But we're not sure how equivalent they might be for the blood vessels, and that's one of the major questions.
Yeah.
Here.
Can I just chime in there? I think it's an important point that Joan makes, is that, you know, this is different than a phase 3 trial where we're testing to see if a drug should be approved, if it works at all, and whether the side effects are reasonable. These are two strategies that are proven, and they're proven to be really very similar with respect to their ability to reduce pain and improve function. So we know that both arms of the randomization, patients will gain benefits, and these are the strategies that Joan and I use in our clinic. But again, the question is about heart issues. That's what we don't really know. We know that they benefit people with RA, but we just don't know which has a relative greater benefit with respect to heart risk. And that's why this study is so important, again, because of the known increased risk of heart issues in people with rheumatoid arthritis.
And one thing to mention that's very exciting is a recent study in people without rheumatoid arthritis who were treated with one of our anti-inflammatory drugs. So people who had had a prior heart attack were treated with an anti-inflammatory drug that we sometimes use for RA, and it's used in other inflammatory conditions, called canakinumab, and it was effective in reducing the risk of heart attacks by about 15%. So there's already some evidence in the general population in people without inflammatory diseases that our drugs may be effective in reducing heart risk. But we've not studied it in rheumatoid arthritis effectively.
Wow, that's great. So I'll just remind people that we'll send out this information or make it available on the website, and remind everyone who signed up for the webinar that where you can find this information. And for specific questions, there's a research coordinator that you can contact to ask questions as well. So I know it sounds like there's a lot of interest, and especially in this topic, and as a result in this trial as well. So given that it is the top of the hour, I'm going to say thank you very much to our two presenters for taking the time to walk us through these important topics on clinical trials in general, on cardiovascular risk in rheumatoid arthritis, and then also on this particular trial that they're leading, the Target trial, to help answer an important question: does it lower the risk of cardiovascular disease to be taking a particular RA treatment? So thank you so much for your time, everyone, and we'll be in touch via email soon.
Thank you very much.
Very much. Bye-bye.
Bye-bye.
Bye-bye.